Hi, welcome everybody to TCCW Live. We are here with Dr. Malea Jensen. She is going to give us a bit of her story, how she ended up in the carnivore space, and we're just going to expand upon some random topics. As we know how we do it here, it's all impromptu and just informational fun. So, Dr. Jensen, can you please tell us, how did you end up in a carnivore animal based, whatever label you want to put on it,
Sure.
lifestyle?
Sure. Selena, thanks for one. Thank you for allowing me to engage with you on the live stream. It means a lot to me. And hopefully we can teach some people, a little bit more about what the carnivore lifestyle or the ketogenic lifestyle has to offer as far as medical concerns, chronic medical conditions, medications, just lifestyle in general. I've been in family practice now for 27 years. And, I started out basically regurgitating everything that I was taught in medical school. So I went to medical school in Des Moines, Iowa, and graduated and did a family practice residency in Des Moines, Iowa. So I went to an osteopathic medical school, and I took an MD residency, and I took MD boards. So I'm kind of a mixed breed, and there's not very many docs that do that. They usually stick either with the DO or MD. But I knew I wanted to stay in Des Moines, and I wanted to do an MD residency. And there's not really much difference. The education is almost exactly the same. The curriculum is underwritten by the exact same people. So it's not that much of a difference. It's just that an osteopath will get a little more training in manipulation and maybe whole body, care, although that might just be a nuance, but who knows? Anyway, I got great training here in Des Moines. And things that you might not know about me is when I was in residency and maybe my early years of practice, I was involved in bodybuilding. And I think that would probably be the area where I learned how important it was to be on a ketogenic diet. At that time, I was actually low fat, low carb, no carb, and high protein. And that got me ready for stage. So I was ready to get up on the stage if I followed that particular diet, and it worked. And I figured if people could follow a low carb diet, they could improve their well-being. I knew it worked for me, and I have followed a low carb diet for the last 27 years.
Wow.
Now, there's been years where I let things slide. We all do it. So I can't tell you that I have been extremely low carb for 27 years, but I've been in and out of that. And I've seen a lot of people heal on a ketogenic diet. And that is probably what led me into the carnivore space, because I think that's important for people to understand. But again, not everybody can do this diet. Not everybody can do this lifestyle. Right. And there's going to be caveats. And we can talk about those, but there are people who may not do as well with a complete carnivore diet as others. Let's just put it like that. Okay.
Okay. So with that being said, what are some of the obstacles?
I can't hear you. You might be muted. I'm sorry, Selena. I can't hear you.
No, hold on. Hello, hello.
Let me see. Mine is, I can unmute me, but I can't hear you.
No.
There you go.
Okay. I'm like, I told you, it's been a week. It has been a week. So based off of what you said just now, what are some of the obstacles or issues, if that's what you want to call it, that some people might run into that may not allow them, from your perspective and your experience, a full carnivore lifestyle, or troubles that they might have with that?
Sure. First, let's define a carnivore lifestyle. Okay. Specifically, carnivore is a animal-based diet that is low or no carbs, moderate amounts of protein, and higher amounts of fat. In nature, animals are going to come with protein and fat. Okay. You're going to get your omega-3s. You're going to get your omega-6. It's going to be a complete package when you consume an animal product. Okay.
Right.
When we talk about a carnivore diet and a person goes and follows that particular diet, let's just say, so it's moderate protein, high fat, maybe a 1-to-1 ratio, maybe a 2-to-1 ratio of fat to protein. But here's where we can run into some caveats. And we have to take all of this into consideration. And I want to give you an example because many patients are still fearful of cholesterol. They are, even if the food pyramid turns upside down 10 times, because of our background, because of the way we've been cultivated to believe, we've been, I want to use the word loosely, but indoctrinated in such a way that it's almost hard to unlearn that cholesterol causes heart disease. Now, most people in the carnivore space would look at a lipid panel, a cholesterol panel, and say, hey, if your triglycerides are lower than 70 and your HDL is greater than 70 or greater, you are in a metabolic sweet spot and your chances of having heart disease is very low. Now, I think anybody listening in the carnivore space right now or ketogenic space would say, yeah, doc, that's exactly what I tell my clients is low trigs and high HDL, and the LDL doesn't matter as much. Now, that's all fine and dandy, and it works for 80% of the population. But there's a certain population that might not work for. And let me give you an example. If a person that has that type of lipid panel also gets a nuclear magnetic resonance imaging, so they get an advanced lipid test.
Right.
Advanced lipid test is going to share with you or the patient, the person who's ordering it, it's going to share particle number and particle size. So when we're reading, just as a little background, when we're reading a normal lipid panel, gives cholesterol, it gives LDL, it gives HDL, it gives triglycerides. Cholesterol on that lipid panel really means nothing. You can't measure cholesterol in the blood. The blood is water soluble, and cholesterol is not water soluble. So you're not really measuring cholesterol as a number itself. What you're measuring is the LDL particle or the HDL particle that is carrying cholesterol. So when we break down and get an advanced lipid test, we're actually measuring how much cholesterol is in an LDL particle. How many LDL particles do you have? And then what is the size of the LDL particle? Is the LDL particle large and fluffy? He's got a lot of fat and cholesterol inside of him. He's like the little caboose or the train, one of the cars on the train that's going down and delivering all of its contents to the cells and the areas that need it. All right. And once it dumps off all of the stuff, then it gets recycled back into the liver, and then it gathers up more stuff, more cholesterol, whatever it is. And it's a whole train with a caboose and a choo-choo, right? Okay.
Right.
So when we get down to that advanced lipid test, what if the person who you originally thought was in the metabolic sweet spot with low trigs, high HDL, ends up showing small, dense LDLs? Because normally, if a person has low trigs and high HDL, their small, dense LDL count will be very low, because small, dense LDLs tend to go down, let's just say they go up with carbohydrates. The more people who have high carbohydrate diets, the more small, dense LDLs there are. And we're now being trained that, okay, maybe it's the small, dense ones that are the problem. They're sticky, they're small, they get eaten up by the macrophages, they form foam cells, and then the foam cells are a component of the plaquing inside the arteries. So you can see where small, dense LDLs are getting a bad rap, okay? So
Right.
if we have the person who's got these low trigs and high HDL, and you go, how in the heck does that person have all these small, dense LDLs? Is that a mess up? No, it's rare, but it's likely not a mess up. And you can recheck your lipid panel or the advanced lipid test to get an idea that that person is unable, hear me out, they're unable to tolerate as high a fat diet as they're taking in.
Huh.
They are taking in so much animal fat. They might be taking in the animal themselves, their T-bone, their ribeye, their 70-30 ground beef, and that amount of and butter and tallow and eggs, that amount of saturated fat for that person, they can't
Right.
tolerate it. So what is being exchanged? The liver is getting all kind of bottlenecked. It's choked up. The liver is choked up. It is trying to take care of all of the saturated fat that we're consuming by having more and more LDLs out there, right? But these LDLs are not being recycled back into the liver. The receptors are down. And so that leaves us with dumping off more and more and more of the inner contents of a big LDL, now making a small, dense LDL. That small, dense LDL can be oxidized by anything, by sugar, by iron, by polyunsaturated fatty acids, by anything. So this is the caveat that I think we might be missing the boat. And, you know, if doctors don't know this, this is a thing that you have to really train for. You have to understand that lipid panel. And there's not a lot of docs out there who understand it. And I caution our coaches and I caution our, you know, just the influencers out there who look at just a regular lipid panel. And I know this, it's easy to be, it's easy to be skewed by the numbers. You could even, I'm talking, Selena, I could even add in their insulin level in this particular person could actually be 2.83, okay, which is a normal insulin. An optimal insulin is somewhere between 3 and 5, okay? And that is optimal. And you go, okay, this person has a low insulin, their trigs are low, and their HDL is high, their waist size is so-so, you know, and I'm going to get to that point. But you get an advanced lipid test, a nuclear magnetic resonance imaging on that blood, and you see all these small, dense LDLs. Then you start piecing together the history from the patient, and they say, gosh, doc, I felt great when I first started this diet, but now I'm kind of tired. I just don't have the energy that I used to for my workouts. And I hear you talking, doc, all the time about you need to lift heavy weights and do deadlifts. And I say, yeah, but I just don't feel it. I'm not feeling it, Dr. Jensen. And what am I doing wrong? I'm starting to get a little fluff on my abdomen. I don't know why I'm getting this fat. And I can't lose weight like I used to. You would think that I'm carnivore, I'd be losing all this weight. So those are the triggers that get me thinking, what's going on? Then I start looking. And luckily, some of these patients will get an amylase level, or they'll get a lipase level, or they'll get a leptin level. And you'll look at their leptin and it's like 3. And you go, okay, what's not fitting here? Okay, what's not fitting? This person cannot tolerate that much fat. And they can't tolerate the saturated fat. So what you might need to do with this person, what the influencers are telling you, and I know you've heard this, Selena.
Oh, I'm sure.
Eat a little bit of carbohydrates.
Yeah.
If you just eat a little bit of carbohydrates, then you will trigger your system back in. And that, I think, maybe they don't know why they're saying it, but that's what they're telling them. But you and I both know that there is no essential carbohydrates, right? We could live without them. But the person who's thinking, I got to get healthy, I'm going to get rid of diabetes, and I'm going to get rid of my blood pressure problem, and I'm going to improve my heart function, and I'm going to do all these things because I heard ketones are excellent. And they are. But if this person, this particular caveat person, is eating so much saturated fat, what you and I could probably handle, okay?
Right.
They're getting fatter, they're getting tired, and they got small, dense LDLs building up. what you could do. So here's how I look at it is here is their protein. Here is their saturated fat intake. Let's just say it's a 1 or 1.5 to 2, or maybe a 2 to 1 ratio of fat to protein. No carbs. Carbs are way down here. Okay. So they got their fat. What you need to likely do for this person when you're worried, and they should be worried, because if you have small dense LDLs, there is a higher risk. I don't care what sweet spot you're in for your triglycerides and your HDL, that person is at risk for a heart attack. They just are. Okay. And so if you were to bring that saturated fat intake down, increase their protein intake. So maybe instead of 100 grams, they go to 125 grams of protein. I'm just throwing out numbers here. Okay.
Right.
And maybe they were at 125 grams of fat and you're going to lower it to 100. Okay. So you're going to actually bump up their protein, which will increase their thermic effect, because protein has a higher thermic effect. So you're going to start burning some of that fat that's on their body. Remember, if they aren't tolerating all of the fat coming in, they're going to use that fat for energy. They aren't even going to dig into their suitcase on their body. They have a suitcase of fat on their body, but they are consuming so much fat that they're trying to burn that fat first. And they now, because of their particular genetics, they could have a receptor problem with the CTEP, the CETP receptor, there's many things. And that's probably why statins don't work for them. That's why Zetia doesn't work for them. But I'm not getting into the weeds with the medicines right now. What I want to train our coaches or train other doctors to hear is, especially when you're promoting a carnivore diet, is we need to look at these things and look at the caveats. Because if we were just to lower that person's saturated fat down, increase the protein, and then whatever saturated fat we are eating, guess what? That person would probably tolerate a monounsaturated fat more so than they would tolerate a saturated fat. I don't know why. I don't know that we have all of the science behind it, but this is what I'm finding is I'm not into plants, as you know, I try to stay away from them. But if we were to maybe exchange some of the saturated fat for monounsaturated fat in the form of maybe 5 macadamia nuts or an avocado, those are monounsaturated. Yes, olive oil is a monounsaturated fat, but I stay way away from it. I believe it's cut with other polyunsaturated fatty acid seed oils. They're not 100%, and they're in oil. Okay.
Yeah. We don't make enough olives in the world to produce the amount of olive oil that's on the shelves. Just saying. It's just not possible.
Yeah. And you bring up a great point. I mean, but I think people say, well, the more money I spend on an olive oil, or the darker the bottle, or I got it from Italy, or whatever it is. I just think we're being bamboozled. And that's one of my favorite terms, is being bamboozled by the buffoonery. They know that you want to eat monounsaturated fat because the doctor is telling you to eat a Mediterranean diet. Okay.
Right.
And it's just one more way to bamboozle us.
Yes. 100%. 100%. I was attempting to educate my mom a little bit about, she was like, but really good olive oil is good for you. And I'm like, well, yeah, if that's what you're getting. It's like, but is that what you're getting? Is that what's there? Have you,
another thing, Selena, that you could bring up too. Yeah. Another thing that we should keep in mind when people are talking about olive oil or monounsaturated fats, you have to be aware of the fact that any unsaturation of a fat has a double bond. That is what that means. Polyunsaturated fats means many double bonds in the chain. A monounsaturated fat is one double bond. It's the areas where there's double bonds is where they can be oxidized. When we talk, we need oxidation in our body. Don't get me wrong, but when we have so much oxidation going on in our body, it can be a problem. The membranes of the cells can be damaged. The mitochondrial membranes can be damaged. We're taking in all of these unsaturated fats. we're eating foods with boxes and, in boxes and bags with barcodes, as Dr. Bickman would say.
Yeah.
We're consuming these. Now, on a carnivore diet, and you say, well, I want to put in some monounsaturated fats. Just remember that they are a type of unsaturated fat, and there is exposure to being oxidized. So I do tell my people, do not, if you're going to drink olive oil, drink it. Okay. It is what it is, but don't cook with it. You're
Yeah,
oxidizing it right there in the pan.
exactly. Exactly. Um, I did finally get her to stop using it as a cooking oil probably about 6 months ago, and I'm just like, "Thank you, thank you." Like, please. But, you know how it is sometimes where people, like, you could be the most profoundly educated person on a subject, but if you're really good friends or you're related, they're gonna listen to somebody in a suitcase from another town. Like there's that,
Yeah.
that it's a hard thing, I think, for a lot of, like you said, coaches and people who are trying to help advocate for awareness as to what is actually best for us, awareness for what is just, like, scientifically logical, and what I mean by that is the sense of when you look at these packaged foods, they are a science experiment. That's logical. It's not real food. Can it be digested and absorbed into the body to some degree? Of course. So does poison. So does, like, your body's going to utilize whatever is put inside of it at the capability it has to do so. Is it most optimal?
Right. The fake food that we're talking about is processed. It's high in sugar, or it has sugar in it, and it has polyunsaturated fatty acid. And those PUFAs, that sugar and that processing is kind of the terrible triad of what we're trying to do as a community to share with people. Now, anybody who goes from a standard American diet to any other diet, whether it be keto, ketovore, carnivore, lion, or vegetarian or vegan, they are going to show improvements. Okay. They're
Right.
they're going to feel good because they're coming from the worst possible, not food, like you say, it's fake food, and they're going to usually a whole food diet. Okay. And they're going to feel amazing. And so that's what I think triggers a vegan to go vegan. But what
Yes,
they
yes.
don't realize is that actually isn't a complete diet. You could never live your rest of your life eating vegan without any supplementation. If I took you and
Agreed.
dropped you off on a desert island and all they had was plants, you had your fruit and you had your vegetables and nothing else. There's no B12, there's no choline or carnitine or carnosine or any of that. That person is not going to live as long as if I dropped a person off on an island full of animals and they hunted and ate those animals.
Right.
It is what it is. You could
So
not, I believe, correct me if I'm
oh,
wrong, you could not survive long term on a purely vegan diet without supplementation.
I will tell you from my own personal experience. So my mother raised me vegan, vegetarian for the primary portion of my young childhood. So she breastfed me, thank God. And then after that, I was pretty much vegetarian. I became vegan for a short period of time. I then, kind of like bounced back and forth, was then vegan. Yes, I was then vegan again from the time that I was 14 until I was 26.
Wow.
So by the time I was 24, 25-ish, I was getting unbelievably sick. I was so sick. And, like, on top of all of the other things that I, ended up experiencing and having and finding out later, "Oh, this is how I ended up with cancer," right? But I was so sick. I went into the doctor, had some, like, blood work done. They were trying to figure everything out. Of course, mind you, I'm vegan. And they're like, "Well, you need to start adding in, some sort of proteins. This isn't quite working for you. You're missing all of these. Like everything on my panel was basically plummeted in the trash can. I mean, everything. And so I was like, okay, well, I can add eggs. So now I'm vegetarian. Okay. Now I can add eggs, and now I'll add dairy, and that should help, right? Even 2 years into that, my only option came to a point of you need to start getting injections every week in order to survive, or you need to start eating meat. That was my option. For me, it was like, okay, I was not vegan because of the common morality aspect of not eating animals. I was vegan purely because I was raised in this very holistic lifestyle, naturopathic lifestyle. And what typically is aligned with that environment is vegan or vegetarian type living, or as high a plant base as possible. Rarely are proteins extremely advocated for in a, sort of holistic, be it hippie lifestyle, right? It's not. I started adding chicken in because I was like, there's no way in hell I'm going to go in and have injections every week just to live. Something's not right with that, right? So I started having chicken. It took me a couple months to be able to even get to a point where I could digest it okay. And I'm going to tell you, just from that chicken alone, a night and day difference. And that's not even the most optimal meat, right? Like night and day difference. So I could tell you from personal experience, as someone who lived a vegan and vegetarian life for the primary portion of my life. My mom was vegan when I was conceived.
Oh, wow.
like it's, there's a night and day difference. And I was
Yeah,
told very clearly,
you were malnourished in the womb.
yeah.
I mean,
And
you're
she was
really lucky to be here.
ultimately, yes.
Blessed.
That's why I say, had she not breastfed me, I probably would have been totally screwed, because as much as she had to offer me from her own system, I took everything, obviously. Like, her body offered me everything she had to offer because she herself, as a vegetarian, didn't have much to offer.
Yeah, I bet her teeth went bad. Oh my goodness. I bet she's got osteoporosis. I mean, there's just so many things, but
Right. She
gosh, what a
eventually started
story.
eating meat again. But so I could tell you my own personal experience. A doctor who could care less and thinks vegetarian way of eating is the most optimal still told me I had to either go on injections to get all of my right nutrients, or I needed to eat meat. I mean, it doesn't get more simple than that.
Yeah,
It just doesn't.
that's quite a story.
Well, everybody has amazing stories. They're
Right.
all just different. I look at I think most people don't realize how much they've been through in life until they start telling it. That's why I love having people come on and being able to share their experience and what they're going through and the realities of what's happening to us in society. I
Yeah.
think we have another guest who's about to be able to join in, and it's been a hot minute since I've seen him on our stage, so I'm going to bring him in with us. I'm sure you've seen him before. So welcome, Michael.
Hi.
Hi, it has been so long, my dear.
Oh, it's funny. We plan and we try to have, everything that we would like to do, and then God laughs.
He
So,
might be on mute too.
oh, am I
Oh,
on mute?
no, I can hear you.
Can you hear me?
I hear you, but she can't
Okay,
hear
I
you.
can't hear Mike. Oh, there we go. Okay.
Can you hear me
Are
now?
we good?
It might
Yeah.
take a second. Some refreshing.
Yeah, no, and I'm trying to remember how to put this onto my live stream so it could kind of be extended out. I'm trying to remember how to do all that.
It is quite a conundrum with figuring out the tech stuff. Her and I were talking about that before we started. I'm like, man,
It's
this
so weird.
society.
I had no problems doing it last time, but I guess it's been like 16 weeks, I feel like, since I've been on a live with you all.
Probably has been 16 weeks.
Okay, I can't hear Michael at all.
So if I
Oh, no.
What about now? Can you hear me now?
I can. I don't think she can.
No,
Can
I
you-
can't.
That's so weird. Should I log off and try logging back in? Let me try that.
Yeah, try that and let's see.
Okay.
Because I don't have anything like restricted on the guests, so there shouldn't be any stuff saying no talkie. So as you were saying before, I kind of like threw the conversation in there about being thrown on an island. Yes,
Is that working? Can you hear me now?
still don't think she can.
No.
Oh, you know what? Then I'm going to try going on my iPhone because it could be, maybe it's a computer thing. But that's weird because this is StreamYard. So I've never had an issue like that before.
Me,
Selena, is it somewhere on your end where you need to chime us both in?
I am going to see. I'm going to pull you out for a second,
Okay.
and then I'm going to throw you back in and see.
I swear I didn't mean to be such a problem.
You still can't hear him, can you?
No.
No. Okay.
Okay, so my login code.
Maybe, Dr. Malea, will you try backing out and backing back in? Seeing,
Yeah. How do I do that? Just exit and hit the link again?
yes.
Okay.
Hello?
Did that work?
Well, I don't know. She's also going to back out and come back in. Gotta love technology.
I know, right? I'm sorry for messing it up. You guys are having such an amazing.
No. No, it's not a mess up at all.
All right, I figured out how to. So while she's doing that, I'm going to link it to my live stream. So hopefully that'll help get a bigger audience. So this is premising, we're talking about body cholesterol. We're just kind of going through just so I could come up with a title for this.
Yeah, she's talking about cholesterol. We've gotten to a point about being thrown into a vegan environment. If we were dropped on an island and had no way to hunt any food or get any type of animal proteins, that we would not survive.
Yeah.
Right. That's kind of where we were.
That's exactly the truth. And it's and even if we're able to survive for a period of time, I mean, what we could tell is, and you can see this from vegetarians that have been, eating that way for 50 years or whatever it is, the plants start to take away all the nutrients from your bones. So like you may be living, but you're living in your most weakened, vulnerable state.
Exactly. Dr. Malea, can you hear him?
Yeah.
Okay. All right. Can you hear her now? That's the question.
Yes, I can.
Okay.
I entered in a good spot where he was talking about the bones, and that's where, with plants.
Yes.
Yeah. All right. You guys can take it away. All right. Welcome to the show, guys.
Thank you. I mean, that's
Selena, I wanted to comment on something you brought up, that we are all in our, that you were talking about the population in general, maybe not being educated. Is that what you were maybe mentioning earlier? That one of our goals is to, get ourselves out there and educate the population.
Yes.
I think what is
absolutely.
difficult, and you mentioned this before, is that, it was hard for you to even talk to your mother, but they will listen to, somebody like their doctor, and they put all of their chips in their doctor basket. And
Absolutely.
they don't broaden their horizons, so to speak, and listen to other people. It is very difficult, even for a physician. And if it weren't for some of my patients who said, I think you're wrong about what you think. And I said, how could I be wrong? This is what I was taught for, the last 20 years. How could I possibly be wrong? I went to medical school. I got an education. It doesn't mean anything. We were taught the wrong things. I think we were taught the wrong things. And it's going to take the population to empty out those experiences, just like I did, and put
Yeah.
new experiences in. So
Absolutely.
from you, Selena, from Michael, from Brian, from the carnivore space, or just in general, a ketogenic space, just in general, is there
Yes.
are no essential carbohydrates. We've mentioned that before. Now, are there going to be people who eat or consume some carbohydrates? Yes. And if they feel great, great. We can't knock them. But we can also share, about oxalates and phytates and tannins and saponins and everything else that Michael was likely talking about when I jumped back in here. So it is humbling. You have to be humbled and say, I don't know it all. And I say that to my clients all the time. I don't know. I might not know, but I'm on this journey with you, and I'm going to continue to learn, because what I learned today, eggs are good. In 3 years, eggs might be bad. I don't know. But what I'm going to share with you right now is what I know right now, that LDL cholesterol, or cholesterol in general, is not the cause of your coronary artery disease. That's not the cause of your heart attack. It's a combination, but we got
That's
a lot of
the
learning to do.
that's
the
the
truth.
best way, I think, to approach anything. I have explained to, whether it was clients, whether it's in my other working space, if I don't have an answer to their question, I never try to make any kind of BS up to tell them. What I tell them is, you know what? I don't know the answer to that right now, but I'm going to do my best to find it out for you. I'm going to do my best to find out so I can help you the best I can with the knowledge that I can gain from this. None of us know everything. None of us even have 100% certainty. Like you said, who knows what 3 years from now we might discover something so profound and we're like, crap, we got it wrong too. Who knows?
But again, that takes a humble person to admit that we were wrong. I mean,
Right.
I have stated to my people online, in my patient office, in the patient room, I said, I was wrong. I believe I was wrong, and I told you the wrong things. And I've had patients tell me, it's okay, Dr. Jensen. We didn't expect you to know it all. But they do put so much into you. And even, for Michael, you might have every single answer. You might know what would help that person. And you are competing with that person's doctor.
Mhm.
Yeah.
That person's doctor, who they've put all of that energy, all of their chips into that one basket. Why would my doctor hurt me? My doctor went to medical school. They have this training. They have all this education. They can't be wrong. And you have to fight against that. And somehow in your coaching technique, you have to share with them that we don't know it all. And I just want to get you to open up your brain, because they're not opening up their brain.
No.
They're
Yeah.
only listening to what their doctor has to say. Okay.
Exactly.
The garbage man might know more than your doctor. It's unfortunate, but the doctor has blinders on, and they know whatever the guidelines are. Whatever a guideline says, they follow the guideline. They won't get sued. Get their LDL down to this, get their blood sugar
Right.
down to this. If their A1C is 7.5, great. No, it's not great. That person is dying. Okay.
Yeah.
That's where we're at right now, is we got people out there listening to Michael, listening to Selena, listening to Dr. J, listening to Brian, listening to all the influencers, yet all of their chips are in one saying, my doctor wouldn't hurt me. Well, your doctor doesn't know it all, and actually probably doesn't know anything. I mean, to be honest, all they know is what a guideline says.
And if the guidelines are all based off of, data from sick people to begin with, how can you even say those numbers are correct? I mean, have you been in a situation where I was working with a client where they were talking about how they were having some liver issues, and I was explaining to them how consuming liver, being that it's has everything that your liver would have in it, could be extremely beneficial. And they said, well, excuse me, I need to talk to my doctor to make sure that's okay, to make sure it doesn't interact with any of the medications that I'm taking. And my response was, well, if you went to a restaurant and they were serving liver pate, would you call your doctor before eating it? Well, no. And the moment that happened, that showed me just how cognitive dissonant people are, because from the very beginning, we are taught to just accept what they say because they are the professionals, like you were saying. And it doesn't take until somebody gets really sick or starts noticing that the recommendations aren't working the way that it should, for you to start cracking that, putting little cracks in the matrix for you to really start to see things for how it really is. But it's so frustrating that so many people just aren't there. And they're so quick to just accept whatever it is that their doctor wants to tell them. Even if
Yeah.
all that includes is adding another medication. Nothing else changes but more medication.
But that's what we've been trained, Michael, and you know that. You know, I went to medical school, I went to residency. We were trained in making a diagnosis and then giving the medication, supplying the medication that will treat that particular diagnosis. That was our training. We weren't trained in, hey, I made a diagnosis. And let's think backwards on how, let's take it back and say, hey, where did that come from? We weren't into that. Okay. I can't even recall ever I learned all of my nutrition, and you'll get a laugh out of this. I learned my nutrition from Muscle and Fitness, Flex Magazine, and Muscular Development, especially Muscular Development, because there were doctors in there doing articles.
Yeah.
I mean, imagine doctors don't know this stuff. And I'm learning about a ketogenic diet 20 years ago, and that was unheard of unless you had seizure disorders. And then, oh my gosh, a ketogenic diet is great for you. But if you don't have seizure disorders, it's the worst thing possible for you. That is not even logical. It's not even logical.
Right.
No.
And so I'm actually surprised in your description of this person, one of your clients, who said they had liver disorder, because the reference range for normal liver is upwards to 40, 45. For AST and ALT. You are missing so many people with fatty liver disease, so many people with cholestasis. It's unbelievable. A normal AST and ALT should be 10 to 15. I'm so surprised that that person, they must have been 80, 2 or 3 times normal, to tell you that you had a liver disorder. It was probably 120. And they go, I think I have something wrong with my liver. Yeah, I can tell.
That's absolutely right. Have you come across someone that has issues with their kidneys that don't have issues with their liver? Because I find they are completely connected.
Yes and no, because maybe we didn't check everything that I need to check for liver.
Okay.
Now, kidneys can be influenced by different things, okay? So if you're only looking at the BUN and creatinine, the BUN and the creatinine, you're going to miss a lot, because you're missing a person who might be under stress. They might be more physically active. They might have high body mass. Their age takes into effect. And so to get a very accurate kidney, you do a urine microalbumin and you do a cystatin C. Cystatin C is more accurate than simply just getting a BUN and creatinine and getting a GFR, because that person could look like a normal kidney function with a normal GFR of, which again, we're looking at reference ranges again. All GFRs should be above 90 to be optimal. And what doctors look at is if it's greater than 60, estimated GFR, you're fine. No, you're not fine. What if it's 61? You're in stage 2, stage 3A, almost stage 3A, chronic kidney failure, chronic kidney disease.
Wow.
So we're not looking. And, all of our organs, they don't just sit independently in our body. To add to what you were just saying, we are in a system. They don't work independently, although doctors treat them independently. You go to your lung doctor and your heart doctor and your liver doctor and your GI doctor and your whatever doctor, your gynae doctor and your urology doctor and your nephrology doctor, and they all work independently trying to fix the kidney. When the liver, like you say, is fatty and choked up and under pressure, and it's trying to do a whole bunch of other work when it should be doing this work over here. And that's a sick person because they have no glutathione. And I mean, it goes on and on. It's like a tumbling dominoes. Yeah. Doctors aren't putting everything together, and they're not looking at the right things. They're looking at reference ranges. So to answer your question, do I ever find a person who's got liver disease and no kidney disease? Yes, because I didn't look at the other things. Okay. They could look like a normal kidney. And then I get a cystatin C and I go, oh boy.
Yeah.
No, they're not healthy. They're spilling protein in their urine.
It's crazy. And then to go off of the same thing that you were saying there, I mean, doctors, even if a client comes in and they have a patient that has a fasting glucose at 110, triglycerides above 100. They won't even tell their patients that they're really at a risk unless their fasting glucose gets to above 120 or gets to like that 120 point. It's just crazy how, like you said, with those ranges, how within that range, you could literally be in serious trouble and think that there's nothing wrong, which I think is one of the biggest disjustices to patients. And I think it's one of the biggest misinformations that doctors are sharing, because just because it's a range and you fit in it doesn't mean it's right. And if you start looking into statistics and you start looking into outliers, you start looking into what is really going on, I mean, it's so blatant. But if they actually gave you the real numbers and said, if you're here and you're here, you have a problem, now everybody's going to be worried. Everybody's going to start acting emotionally. They may not listen to their doctors as much because they've been following their doctor's orders, which is basically how they got here to begin with. Like me, I was told, eat healthy, don't have a lot of red meat. So I ate a lot of vegetables. I had rice. I had, oatmeal because they said that was good, limited red meat, a lot of fish, a lot of chicken. IBS, psoriasis, depression, anxiety.
Yeah, I know your story. Yeah.
It's just insane.
It is. You mentioned something here about the, gosh, now I was thinking and I didn't want to interrupt you, and I probably ended up interrupting you, but I think what I heard you say is the person taking into consideration about the doctor knowing, this is my doctor. Here's the caveat to that very first part where you were talking about the glucose. So you know as well as I do that the reference range, right? We're familiar that a reference range is basically all the people that come to the lab, right? And it could be mostly the sick people because the healthy people aren't going to the lab. Mm-hmm. But let me ask you a question, and I want you to answer it. I want you to answer it from not what you know now, but from the person you used to be. Okay, just try to go back in time, and I want you to hear me out, and I want you to tell me how you feel. I'm your doctor. I look at your results, and I say, Michael, gosh, you look good. I mean, look at you. You're lean, but you say, but doc, I got some fat on me, and I feel tired. I say, but Michael, you look good, and I'm looking at your labs right here, and they look good too. So you look good, Michael, and I'll see you in a year. I feel very confident that you look good. I'll see you in a year. Tell me what you feel right now.
What do I feel? I feel confused because I just said that I'm feeling tired, but you're telling me that I feel good. But if you're telling me that I'm good, then what I'm feeling, I shouldn't be feeling. So I'm just going to go home and I'm going to keep living my life, and I'll see you in a year.
Right on. Because you took everything that doctor, must have the authority, that it actually distorted your reality. Mm-hmm. Because of my ectalon, my eliteness, I tell you, you look great in person, you look great on paper. So by you knew you didn't feel well, but I distorted your own reality. I made you even question that you even have a stomach problem or a rash. I could even tell you, Michael, that's pretty normal. These are normal things that you're going to get with aging. And you likely had some genetic,
you're just getting older.
Thing going on. Did your mom have psoriasis? Oh yeah, she had psoriasis. It's genetic, Michael. You know what? You're good. You're good. I'll see you in a year, and you let me know if you need anything. Do you see that the confidence, and I actually distorted your reality. I felt confident. You said, gosh, Dr. Jensen told me I'm great. I must be. These things I'm feeling must not be real. We do that to people all the time. Maybe we don't even know. Maybe we're just that negligent. And I call it ignorosis. It's a condition, osis, of ignorance.
I have to agree with you completely. Because again, very similar to what happened with me. I was feeling all kinds of symptoms, right? I was lethargic. I was absurdly gaining weight without reason or justification. I would have dizzy blackout spells. I mean, I was going through, there was like a list that I could fill up a legal pad front and back on a page without question, right? And by 3 different doctors, it's just because you're overweight. As soon as you lose all this weight, That's what's causing all these symptoms. You'll be fine. Never once put together all of the combination of what I was going through and went, God, we probably need to look into something a little deeper, a little heavier. Not once did anyone even request a thyroid panel. I had to go pay for that myself when I started doing my own research into what the hell is going on with me. What's wrong? Because obviously, yes, carrying excess weight is a problem for the body. But when you go from being a standard size, right, to gaining 70 pounds in less than a year, that's not your diet.
No.
My diet didn't suddenly change so drastically within a year that I just put on 70 pounds, right? like this to me now, especially, is like common sense. But everything that a doctor reassured me of that confirmed from their perspective was, I just need to lose weight and all of these problems will go away. All of these things I'm experiencing will go away. And it's like, that has been such a profound experience for me in dealing with the medical system. And I know a lot of people think that I have such a distaste for doctors, and I don't have a distaste for doctors because it's exactly like you just said, Dr. Malea, right? It's an ignorant, unknowing place because of where the medical system has put doctors in this box of authority that they don't know. They don't know all the time that they are not helping you to the best of their ability. The doctors that I saw, general practitioners, my awareness came in so much so when I started doing my own research in realizing they do not have the ability to be able to fully comprehend every possible issue with every possible everything that could ever walk in those doors and ask them. They don't have the time to learn all of it. It's
That's because
impossible.
the system is skewed towards seeing more patients. The system
Exactly.
is skewed to see as many patients as possible. Okay. I've been there. I worked in corporate healthcare. So what I mean by that is a big hospital, corporate clinic. We were seeing 40 patients a day.
Right.
I mean, that leaving you 5 to 10 minutes per patient. I couldn't even think. Okay. I did the best I can, and we make mistakes, but that's what we were incentivized for. If I want to pay back my loans and I got to do these things, I got to work extra hours, 12-hour days, seeing as many patients as I can, pay back, do the thing, just don't hurt anybody. Okay. See a bunch of colds, do the thing. And it's not right. And finally, after I probably did that for 14 years, I bet I did it for 14 years. And finally, I said, I can't do this anymore. I remember talking to my dad and I said, this is not healthcare. I'm not giving good healthcare to people. It's bad. This is bad. And he goes, well, what can you do? And I said, I don't know. And then when I tried to slow down, you kind of got a bad rap in the clinic. I mean, the doctors will say, you're not pulling your load, basically. And so finally I said, I can't do this anymore. And they don't care if you're there or not. They could replace you now. Maybe now these days they can't, but they can replace doctors very easily. So I went out on my own, and then I started only seeing 10 to 14 patients a day, which is much more manageable. But you can't pay back anything on 10 patients a day. It's next to impossible. So you're talking to doctors who are incentivized by making enough money to pay for their lifestyle. And do you expect that they're going to take the time outside, Selena, outside of their work day, when they got to go take their kids to practice? They got to go to they want to go to the opera with their wife. They want to have a sit down dinner. They're not going to be reading journal articles, and the journal articles, they're paid and bought for by the same people who paid for who underwrote our medical school. We do continuing medical education. All of the continuing medical education is written by the exact same people who do the curriculum for the medical schools.
Mic drop.
There's
Yes.
no outside training. So the patients are smarter than the doctors because they're getting informed consent and being their own doctor. I always tell these people, and you guys should too, the best doctor you'll ever have is staring you back in the mirror.
Yeah.
We need to encourage everybody to educate themselves.
If you don't educate yourself, you leave yourself in a situation where you could be manipulated and skewed, which is basically what's happened. And to go off of what you were saying, it doesn't sound like you were really in a clinic. What it sounded like is you were in an office where they wanted as many drug dealers as they could have to be able to push as many scripts as they could have. So a patient would leave, there'd be a copay coming in. Who knows what benefits there are between pharmacies and that business, to where if there's any type of back and forth, as we're starting to see, because we do know that there is that within the medical field where there is incentives for doctors to do different things. And breaking away and you being able to have that moment to actually be a doctor, to be able to care about your patients, to give them the time that they deserve without feeling the negative animosity from everyone else in the clinic for not carrying your weight, or the way I look at it, for not doing this enough times on a script in a script pad in a day, is really sad. And I'm glad that you were able to break away and you were able to expand your knowledge. And I'm sure once you broke away, that's when you really were able to start educating yourself in an even further, deeper manner, which is kind of what led you here today. And look at how many people you probably have helped get off of that hamster wheel that everybody else is stuck.
Yeah, thousands, I'm sure.
I mean, those are the ones you know of that speak to you.
One clarification I will kind of set straight is, when I was in that hamster wheel, as you call it, there wasn't a time where there was ever any incentive for writing a prescription. And let me be frank with you. They actually didn't want us to be writing prescriptions. And if they did, they wanted them to be generic, because back in the day, or even now, there's a pool of money and they want to keep that pool very tightly bound. Okay. And I will be honest, they didn't even really want drug reps coming into our clinics, because we would be influenced and we would write those products. Okay. So say back in the day, Levaquin was a big medication, an antibiotic. Okay. It was before it went generic to levofloxacin. So it was called Levaquin. And I knew as well as anybody, if somebody's got a pneumonia, you don't give that person amoxicillin. But we would be incentivized for not spending money on a brand name. Does that make sense?
Yeah.
And the incentive is the pool of money is there. If there's no money at the end, then nobody gets an incentive. Does that make sense?
Yeah.
So you're incentivized by not spending money. You're incentivized by keeping everything in the system. So if you want to refer you, Michael, out to physical therapy, and you, Michael, want to go to Joe down the street, but Joe down the street is not in my system, I need to keep you in my system, because if I send you to Joe and write the prescription for you to go to Joe, I pay for you to go to Joe. And it's not just me, it's my whole clinic pays for you. So we're not making money by writing prescriptions. There's never really been, you might get a soda, you might get a dinner, you might get taken out to play golf. These are olden days. You don't get any of that anymore. Right. A rep can't pay a doctor unless you speak for them. If I speak for Ozempic, I'm going to be paid by Novo Nordisk. That is on me, and I get taxed and I get all of that. And yes, I'm being influenced but maybe I'm so passionate about Ozempic that everybody should be on it. It should just be in the water. And I'm very passionate about that, I could say, right? And then I'm getting paid to tell other doctors about that. That is the incentive. But to write Ozempic, it's your dime a dozen. There's no money coming. I don't get checks from Novo Nordisk because I wrote 10 scripts of Ozempic, but I will get the reps coming in and say, "Oh, doctor, you're just so smart. You're just the most amazing doctor that's in my territory. And hey, do you need a cup of coffee? I'll run out and get you a cup of coffee." That is the extent of drug reps paying doctors. There is no such thing. And I think we need to get that out of the population's head, because the incentive is not to spend money, especially when you're in a corporation.
Mhm.
Okay. Now, me being on my own, there's no incentive anywhere. I don't get paid by anybody. I'm truly being paid to sit with a person for 1 hour and get the exact same amount of money that somebody got paid for 10 minutes. Time
Yeah.
isn't even a factor. If I gave every piece of my energy to 5 patients a day, I would make $500, say that on average. And then after the fact that you pay everybody out, right? And a person who makes $500 in a corporate, they made that in an hour, seeing 5 patients in an hour or 6
Right.
patients in an hour.
Mhm.
And that could be a diabetic patient, or it could be a cold, same amount of money. I fear that patients out there are saying, oh, doctors are getting kickbacks for writing statins.
No,
Not
they don't.
even a thing.
But what happens is the moment they write that script for you, you will have to come back to the office. They'll have to see you. They'll have to make a judgment, and then they'll write you another script for it.
You'd be surprised how many doctors give you a script for a statin and see you in a year, never check liver function, never check kidney function, never ask you about you're actually giving the doctor way too much credit, Michael, to be perfectly honest.
Okay.
They got so many patients coming in, they don't give a rat's about that patient. They'll say, here's your statin, everything should be fine, it's low dose, I'll see you in a year. They don't even make follow-up appointments. The doctors don't even care. You're giving them way too much credit that they're actually making money. They don't want to see you coming in.
Wow.
They would rather a cold come in, to be perfectly honest. But yes, for me, I had my patients coming in every 4 months, because I was nervous. What if their liver function goes bad I would give them their script, because I thought if we lowered LDL, then we would prevent a heart attack. I actually thought it was protective. Now there's caveats to that. It is, but we could break that down. But I said every 4 months, you got to come in. Why do I have to come in every 4 months? It's the same every time and you don't do anything. I said, I'm just making sure that I'm not doing anything. Exactly right. And other doctors are not even as conscientious of that. So I think you're giving them way too much credit by having you keep coming back and back and back and making money off of you. Not even a thing. They can't see that many people. You would take up all of their schedule.
Thank you. Like, you don't understand, because I guess with me, I look at it how I would handle it, and I figure most professionals would look at it the same way. So you telling me this is actually really enlightening for me personally, because the only doctors that I interact with now is I used to get my blood work done every 4 months because she convinced me I was gonna die, but now I go once a year, and it's the same story. You're healthy. I'm worried about you having a heart attack. Your cholesterol's a little high, Michael. Dot dot dot. But I've kind of walked away from seeing that other side of things, other than like if I was in her case, how I would handle it. So the fact that doctors will literally put somebody on a prescription and not say come back in 90, not come back in 120 days and check it is scary. It's scary. And I tell like my clients, like when you do a diet, wait 90 days. When a doctor gives you a new prescription, they tell you to come back in 90, 120 days, because that's how long it takes for all the cells in your body to basically replace itself, to forget what was there previously to a degree. So if you're putting someone on a medication and you're not having them come in to check on how that's going, I mean, that scares me. And I feel very, very fearful for so many people out there, because I never in my mind thought, or at least the doctors that I've interacted with would behave that way with their patients. And I guess it's very normal.
And here's another thing. There's no education. And this is where you come in, Michael, or Selena, with your clients. If a person is on a blood pressure medicine, right? Find out what blood pressure you are not doctors. I get it. And you're not giving medical advice. I'm not even giving medical advice. I'm giving information purposes only. Okay. This is not medical advice. What I'm saying to you is you need to educate yourself, because now these clients are in your care, so to speak. Okay. And they're on a blood pressure medicine. They're on an ACE inhibitor or an ARB. And the doctor did tell them to come back in 90 days, but they've been checking their blood pressure, right? And everything looks fine. Their blood pressure is fine. And you ask them what their blood pressure, I'm just saying it's 120/80.
Yeah.
If that's the fine. Okay. So it's 120/80, but the doctor, said to come back in 90 days. I'm not going to go back. You need to know, okay, what blood pressure medicine are they on? Because if they're on an ACE inhibitor or an ARB or something like that, those are, or what about Lasix or hydrochlorothiazide, a diuretic? Michael, that you got to go back. Why do I got to go back, Michael? Well, you got to get your potassium checked and your sodium checked, and you got to check your kidney function. All of those things could change. See, the doctor didn't even explain it. I'll see you in 90 days. We'll check some things out. We'll get a blood pressure check. And the patient heard, hey, if my blood pressure's fine, I don't need to go back. It's not enough education. They're not even educating the people. They might know that it's a potassium sparing medication, and we got to check the potassium level, but they're not relaying that to the patient. So the patient is aware and informed, and you're going on this medication, and hey, we can damage your kidneys and we can cause a heart attack because you're hyperkalemic. It's sad. You're right. It's sad.
It really is. And I just don't, and it just gets to a point where the world is against everybody for being able to recognize what the reality really is. Like,
yeah, they'll call you what do they call them now? You conspiracist.
Well, at this point, I just like to be called a spoiler alertist. Because it gets to a point where it's like, I'm not telling you a possibility. It seems to be the result. Yeah, I'm sorry. I lost my train of thought. That was funny.
Oh, I'm with you on that one. I'm like, at what point do we start stop calling it a conspiracy, theories with things, and we start going and I told you so?
Yeah. Have you seen any promises when if a client ever tries to use magnesium glycinate to help regulate their blood pressure a little bit more versus going into like a pharmaceutical grade, like you had just discussed? Have you seen any type of benefits from trying that more of a holistic route?
One, Michael, I think what we need to be cautious about, and welcome, Stephen. I see that you jumped on, but Michael, when we as coaches, I'm a coach doctor, you're a coach, you're seeing your clients. I think we should be telling our people before they go and take any supplement that they need to get their levels checked.
Yes.
They might feel darn well awesome by taking magnesium glycinate, bisglycinate over the counter and get the same benefit and doctors are not prescribing magnesium. And if they do, they're prescribing magnesium oxide, which the absorption it's cheap. I mean, my mom's doctor prescribes her magnesium oxide. Seriously? If you really want to do anything, but you got to think about, why am I going to put my mom on magnesium oxide? Oh, I'm going to help her with her constipation. Okay. Or bowel movement. So that would be great for oxide or citrate. But if I want it to, work on blood pressure and calming and increasing GABA and parasympathetic nervous system, I want to go with bisglycinate. And then you're right on. But hear me out here. If you didn't check an RBC magnesium, and that's the gold standard, not just a serum magnesium, but you want to get a RBC magnesium level. What if magnesium was high? What happens to potassium? Now potassium is high. Now you're at risk of causing a heart attack in that patient by simply giving them too much magnesium. And potassium and magnesium ride together. And if we didn't know that person doesn't know it either. They're taking these supplements and they're causing more harm. It might not be today. It might not be in a month. It might not be in a year, but over time. And then they have a heart attack and they go, oh my gosh, they're hyperkalemic. I wonder why they're hyperkalemic. Oh, it's just got to be that medication. Well, did you look at a magnesium level? No. Did you ask them if they're taking magnesium? No. All of these things need to be checked before we go and recommend somebody taking some supplement. And it might bring down the blood pressure. Just like you said, it's calming. It's going to cause vasodilation, increase nitric oxide, whatever it might be, right? But we could be causing a problem. Mm-hmm. And we just got to be aware of it. And we got to know what the medications they're on. Are we going to give them magnesium and maybe superload them? And they're on a potassium sparing diuretic like spironolactone, or they're on an ARB or an ACE inhibitor. Their potassium goes up, magnesium is up. And the next thing you know, they're in an arrhythmia like AFib. And then they throw a clot, get a stroke, have a heart attack, whatever.
Yeah.
Hey, Doc. Can you guys hear me?
Hey, Steven. Yeah.
Okay,
Yes.
awesome. This is my first time talking, so I want to make sure I was coming through. Doc, can you
You guys
maybe
aren't going to believe
explain?
this. I don't hear a word Steven is saying.
Oh no.
I hear him.
Doc, can you really not hear me? Because the question's for you.
She can't hear you.
Oh no.
I'm so sorry. I can't.
Wait, Steven, do you want to say what the question is, and I can repeat it?
Yeah, sure.
Yeah.
I was wondering if she could tell us what the pathology, I guess, is where excess potassium intake can cause an actual heart attack.
So
Like,
basically, the pathology of excess potassium and how that could cause a heart attack. Like, how does that happen?
Yeah, it's going to throw. Remember that we have a plumbing system and we have an electrical system in our heart. And that plumbing system, we think about the arteries, we think about plaque, we think about narrowing, we think about a heart attack that way. But when we have our electrolytes that are off, we can cause arrhythmia. So we can throw off the electrical standpoint of our heart or anywhere in our body. Okay. So you're messing with electrons, you're messing with the electrical conduction just from having, and honestly, now we go back to those reference ranges again. Say potassium normally can go up to blah, 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 right? So, and then that person's at 5 or they're at 3.5 and they go into arrhythmia. Just because we've thrown off something with the magnesium or sodium, we're taking in too much sodium. And then the potassium goes down and there's an exchange, for every, 1 potassium in, 2 sodiums come out. We don't know these things. Okay. And so we're throwing that person into an arrhythmia. It could be AFib, it could be VTAC, VFib, all of these arrhythmias. The conduction of the heart is being thrown off just by simple adjustments in taking minerals. And
that's awesome.
that can be nerve-wracking as well. And Selena, should I jump off and then jump back on like I did to see if I can hear Steven? So I know people who are listening are going to get it double. I don't know.
Yeah, no, I would. Let's see if that helps. And if it doesn't, then we'll go from there.
Sure. Okay. Let me see how I log in and log out here.
While we're waiting, it's good to see you, Steven.
Yeah, good to see y'all too. Yeah, that's an awesome. I'm glad I got a chance to ask that question because I haven't thought about it recently, but I've always heard that like if you ever look at a potassium supplement, they're super low compared to your daily requirement.
Mm-hmm.
And I always wondered, and they always said like, oh, if you take too much potassium, you can have a heart attack. And I'm like, how is that? Because just from my limited level of learning so far, I'm still still deep diving, still learning this kind of stuff, which is why I'm glad I got to ask that question. When I think of heart attacks, I think of atherosclerosis. So, clotting, plaque, all of that kind of thing. So, but that's very interesting. I hadn't thought about the electrical signaling to the heart and the electrolytes and all that. That's really fascinating. That's another rabbit hole to go down.
Yeah. And what I find really interesting, and when she comes back in, I'd love to ask, but with the amount of coffee that people consume, which typically strip your body of magnesium and all these other nutrients, where does that come into a play now? Because if you're low on magnesium, and as she had indicated, for every 1 potassium, it's what she said, it was 2 magnesiums that is the transfer, correct?
Yeah, something like that is.
So if you're already depleted in magnesium and then you have this transfer that's going on, how many people's bodies are like on high alert basically because their electrical system isn't balanced the way that it's supposed to be, and then how that could affect the heart.
Yeah.
And what's funny is they say drinking coffee is good for your heart. So it's like,
yeah, that was the thing that kind of pushed me to give up the caffeine because I kind of like consoled myself, like there's conflicting information. Some say it's good, some say it's bad. And I'm like, the same people who are telling me it's good are probably the same people who are telling me I need fiber and massive amounts of fiber and I should lower my cholesterol and all that kind of and everything else that's completely contradictory to what I should be doing. So I was like, maybe I need to get rid of the caffeine. And it's been one of the best things I've ever done, by the way, getting rid of the caffeine. So just throwing that out there. I know it's difficult. I know it's horrifying for some people who just love coffee, but I feel absolutely freaking amazing without caffeine. Like brain
don't know
fog
why.
and chronic fatigue, things that you shouldn't have on a carnivore diet. and I had it really bad. It was really, really bothering me. All gone. I see.
I
I see
wanted to
Doctor's
do like
back. Can
a
you hear me?
can you
Yeah,
hear me?
I can hear you guys if you can hear me.
So based off
Hold
of
on,
what you're,
wait. 1 second. Stephen, can you
Yikes.
hear me?
Oh, there we are.
Stephen?
I could hear Stephen.
Yeah,
I can't hear Stephen.
I can hear Stephen, but I don't think Stephen can hear me. And he's gone.
So you were mentioning for every 1 potassium, 2 magnesium, that's the
Nope.
transfer.
Sodium.
Sodium. Okay.
Yep.
So I was misunderstanding that. So then,
Yep.
so then the question that I have, is for people who drink coffee, which strips your body of magnesium, sodium, all these other nutrients, how does that affect your heart? Because if you listen to scientists, they say drinking coffee daily is actually good for your heart, but you're kind of messing with the nutrient basis, kind of playing with the electrical system a little bit on how everything balances. So if they're saying it's good for your heart, but it's affecting your electrolytes, how is it actually good for your heart?
Because God is good and God made so many backup. He knows that we're going to mess things up. And that's why people can survive so long, I think. But our body is so good at accommodating. So if we're consistent with drinking the coffee, right, our body's going to accommodate for it. It's going to find homeostasis.
Mhm.
So this in and out, you know, if you're talking about electrolytes, your body is going to try to find homeostasis because it knows you're drinking coffee. Does that make sense? So
sense.
this person, you know, the natural sodium potassium pump that's working all the time for us senses when things are off. And that's why if sodium is going, you know, let's just say that you're losing sodium or okay, going back to your coffee thing.
Mm-hmm.
When I think about people drinking coffee and they're changing the absorption of the minerals. So anytime you have oxalates or phytates, you're going to decrease the absorption of all positive charged minerals ions. Okay. So you're going to decrease the absorption of potassium and sodium and calcium and magnesium and selenium and zinc and iron, all of those things. Right.
Mm-hmm.
And over time, your body's going to try to figure out how to survive on that. Okay. But what we go and do to add to it is we'll just go take a magnesium supplement and keep eating the phytates and the oxalates and the tannins and the saponins and the sulforaphanes and all of that. That we go and do that. But honestly, God made our bodies with so many protective mechanisms that it's hard to mess it up unless, of course, our kidneys are going bad. Right? So you think about the elderly people, their kidneys are naturally aged and they've been eating a crapola diet for years and years and years. Okay. Then the doctor goes and puts them on some blood pressure medicine or some PPI because they got heartburn, not even thinking about all of the other minerals in our body. There's this, it's so deep. You know, you could talk about the combinations. What I think is fascinating combinations is calcium, magnesium, copper and iron, sodium, potassium, vitamin A and vitamin D. And do the doctors actually, or anybody, let's just say anybody with a little bit of knowledge, are we talking about all of these fascinating combinations and we're messing things up? I think the reason you guys felt better by getting rid of coffee is not so much that you were checking all of your electrolytes, because God is good and he's going to even out those electrolytes for you with the sodium potassium pump and the, you know, the exchanges that are going on. But I think what probably felt the best is you got rid of oxalates and tannins and saponins and phytates and all of these plant toxins. And then you felt great. Okay. You know, I don't think that people are necessarily feeling their sodium being low or their potassium being low or high. They might feel, oh my gosh, I feel like my heart is, it's beating funny. I got palpitations. Oh, you're just anxious. Get rid of the coffee. Nope, that's not it.
Can you hear me, Doc? She's still can't hear me. Can anybody hear me?
I can hear you.
I can hear you. I don't think she
Oh
can.
goodness.
Nope.
Damn, it's like a conspiracy here. Is somebody could just pass this on to her? Is adrenal fatigue actually a thing? Because I used to think that was probably
When I
what was
went
wrong with
out,
me.
I could hear you, all of you guys. But then when Steven went out and then came back in, I can't hear him again.
Okay.
Steven, are you logged in to StreamYard?
No.
Okay, so when I wasn't, I logged in, and then I think Emily was able to hear me. So I think maybe not logging in might be
He
affecting.
just left.
Oh, you left?
Yeah.
So
Are you logged in? No. Out.
Bye. So then going into everything else, because you start looking at different multi-mineral salts like Celtic or Redmond's, but then you start looking at the Norwegian sea salt, where I think they have a little higher level of potassium in it. Is there something that people should potentially keep in mind when they are selecting different multi-mineral salts? If it is more advantageous to have something that has a little bit more potassium in it, or is it better to try to avoid that mineral because you don't want to overdo the potassium with?
No, I mean, I think our body's very good at if we continue to do something, our body's going to accommodate to that. Here's where I would say is for your clients, I would definitely mention to them, hey, I started a new salt, Michael. Oh yeah, what did you try? And then they go into it and oh my gosh, well, that's higher in minerals and higher in potassium or whatever. Okay. I think you should go to the doctor and just get a lab test. No, they won't check anything. Then you encourage that person just to get a complete metabolic profile on their own. It's $10 to get a profile. Okay. We need to encourage people to get their labs checked. And I hate checking labs as much as anybody because you go and check labs, right? And the doctor's going to give you a diagnosis, right? If you get if you get your labs checked, there's going to be a diagnosis attached to it. You get a diagnosis and now there's your medicine, or your insurance company knows you got a diagnosis now. So there's a fine line to be looking into all of these things. And sometimes getting your labs done on your own for $12 is in your best interest. Okay.
It's all the difference. And then to be honest, me being that I'm practicing in Florida, I actually cannot tell a client to go get a blood test. That's not within my repertoire here. But what I can say is based off of my own personal experience, when I went to get my labs done, this is what I need. This is what I pay attention to. And the hardest thing is when they say, can you look at my labs? Which I would love to look at their labs. But again, in Florida, if I look at their labs, that becomes like a practicing physician that's certified. So that, again, it's something I can't do. So it's
maybe
hard.
In something like that, we work together. You pass those patients to me. I go over their labs and then they come back to you. And if the patient, and this is what I do, I have coaches in Canada, I have coaches everywhere. What I do is I write it all up and I okay it with the patient. Would you like me to send this to Michael, your coach? Oh yeah, please do. So then I email and you have everything that we talked about written down. And that educates you. And now you're on the same wavelength with your client. And I would be happy to do that as long as the patient is willing to be handed off to pay more money, for a consultation to go over labs when their doctor's not doing it or even knows how to do it.
Yeah.
It's an option.
Okay. Well, no, I really appreciate that. And I'll keep that in mind. So if we get to that position, I think that would be a really great benefit for them. So thank you.
Yeah. I've had a lot of coaches that found great benefit in that. I have one in Canada. She uses me extensively, and those patients, it's not like I'm stealing their clients because I'm offering to read their labs and to say, hey, I think you need to get more labs, or let's meet, whatever. Okay. But get back with your coach. You need to exercise, you need to eat, you need to do these things, blah, blah, blah.
Yeah. And I just want to say here, if anybody's tuning in right now, the reason why you get a health coach is because a doctor says you have an issue, you need to make a change, but they don't tell you how to actually make that change and how to be able to incorporate those routines and those new habits into your life. They say you have a problem, you need to eat healthy, you need to change your diet. Bye. I'll see you in a year. And that's where we come in, because we actually help educate on what real food is, on what real movement is, and how to be able to actually put that into practice. So a lot of times they're actually getting healed by the people that they're going to just to kind of follow up with their doctor. And then the funny thing is they'll go to the doctor and they'll say, thank you so much for recommending that I make a change. But they don't realize where the change really came from. Has that happened with you, Selena?
Well, let me give you, Michael, let me just give you what a doctor actually thinks. Okay. So the person comes in, right? And the doctor will say what you said. You need to eat healthy. You need to get some exercise. They didn't give any specifics, did they? The patient goes out and hires Michael or Selena or Brian or whoever, right? Then gets some education, right? And then the patient comes back to the doctor, and the doctor is being told, you trained your client so well, my patient, that the patient's coming back and said, doctor, did you know this and this and this? Well, did you even look here? And well, how about this? And oh my gosh, that patient threw you under the bus, made me pissed off. And so that's how there is this bickering back and forth between doctors and coaches and chiropractors and naturopaths and all of these things is our ego. We didn't want to teach you anything, right? So we'll be glad to hand it off to Michael. Yet when the patient comes back all educated, now we just got an ego injury.
Oh, for
right?
sure. Yeah.
That's what a doctor is thinking, just so you know.
Yeah.
Okay.
Or what if the circumstance, they come back, they're healthy, they do a blood test and they go, oh, you're healthy. But do you realize that the way you're eating, you're going to die of a heart attack because now your cholesterol is slightly elevated? And then they put all this false information in your client's head to where then they come back to you and they say, you put me in risk because you understand, like, now I'm at a huge risk of dying. I'm going to have a heart attack. I'm going to have a stroke. But you're feeling good. You're not having, like you said, you're not having any issues with your heart. You're not having issues with your energy. You wake up, you're hungry. You're not, everything is working the way it's supposed to, but your cholesterol is a little elevated. And now I'm the bad guy because you're the healthiest you've ever felt, but now you're concerned of dying. When before you were unhealthy, closer to death, and you were ready to just keep living.
I hear you. There's a definite disconnect. There is. And, Michael, I'm basically an oddball, to be perfectly honest, when it comes from, I'm wrapped up as a doctor in the healthcare system. And was maybe that doctor I was telling you about, where I was showing some offense to somebody teaching my patient who I thought was wrong. So if I'm set in my ways that LDL is the cause of heart disease, and my patient says, I'm going to get a coach. And I go, oh, great. So I don't have to talk to you about your diet and exercise. Great. But then you come back to me, I check these things, your LDL is high. And they say, yeah, my coach said it was okay for me to eat red meat. See, I'm already indoctrinated, Michael. I'm going to say that Michael, I'm going to throw you under the bus and say, he's a zero. He's a nobody. He never went to medical school. He doesn't know. And you're listening to the wrong person. So you can either listen to Michael or you can listen to me. But if you have a heart attack, don't tell you I didn't tell you so. Mm-hmm. Because we're so indoctrinated into LDL is the cause of heart disease. I'm an enigma. And there's a lot of doctors, I can name them off, Barry and Sean Baker, and I could go on and on, Kiltz, and I could go on and on with all the doctors that know better, that this can't be. Don't think logically. If LDL cholesterol was the problem, if it truly was, and I'm just saying in general, LDL, I'm not talking small dense, I'm not talking large buoyant, I'm just talking LDL. If it was the cause, and 70% of the population's on a statin lowering LDL, tell me, why are heart attacks so common? How do you explain that, doctor? And the patient is not educated enough to even, they can't even tell the doctor, but doctor, because of the authority figure, the patient feels like that's Papa, and I can't tell Papa's wrong, or Mama, I can't tell Mommy's wrong. See, they're holding everything back. So they're in this push-pull situation where they're listening to you. They trust you because they feel great. And then they go to their doctor, and the doctor's living in 1976, where LDL and cholesterol are the cause of coronary artery disease, where I was up until about 6 years ago, right? I'm an enigma among these people. So all I can do is encourage you, Michael, to keep going and say, hey, listen to, if you're worried, listen to a cardiologist, listen to Dr. Ovadia, listen to David Diamond, listen to Dr. Jamnatis. Listen, they're going to set the record straight that this LDL, it's not all it's chalked up to be. Well, let's check ApoB, and then we go down another rabbit hole.
It's
Let's
crazy.
check the LP little a, and we go down another rabbit hole. So it's important for us in our journey to just keep thinking logically, open our brain and saying, okay, you know what? LDL in general, probably not the problem. But unless, of course, and this is where Selena and I talked to the first half an hour, is the nuances that can occur, that a person looks metabolically sweet. They're in that sweet spot with low trigs, high HDL, and this person, it happens to get an advanced lipid test, and their small dense LDLs are sky high.
Yeah.
That is a patient that is getting lost in the coaching crowd, because the coach crowd looks at their HDL and their triglyceride and maybe even their insulin level and says, oh my gosh, you're amazingly well. And they have a heart attack.
Wow. See, at the end of the day, everybody should be focusing on, and everybody should look at the calculation of what your oxidized LDL is. Because if you have high LDL, and I say this with pride, for the last 3 years, my cholesterol, my LDL combined, I've been at around 470. There was one time where it dropped 100 points, and that was a year ago when I had appendicitis and I was no longer able to chronically exercise anymore. Diet didn't change. The only thing that did was how hard I was pushing my body every day. And my cholesterol dropped 100 points because I was not destroying my muscle fibers, which, if your body is repairing muscle, what does it call? Your LDL. If your body's fighting something, what does it call on? Your LDL. Vitamin D, your LDL, everything. LDL is like the basis of everything. So why is it something that we need to fear if it changes its range depending on what your body needs? I was killing myself, my LDL went up. I stopped killing myself, my LDL went down because the inflammation went down. So why are people so stuck on this topic? And if
Let me
LDL
ask you a question. How did you measure your oxidized LDL?
you do it, it's a LDL. Hold on, let me look up the test name again. Give me 1 second.
Hey, while he's looking at that, Doc, can you hear me now? Can anybody hear me?
I can hear you. Can you hear me?
I hear you.
Apparently, you're just supposed to talk to me.
I hear everybody else. I hear Michael. I hear.
I don't know if
This is
Michael
so
can hear
weird.
you or not.
So I guess Michael can't hear me anymore either.
I can hear you. I'm
Oh,
sorry.
okay,
I'm
cool.
just trying to
No,
find
you're
this.
just not supposed to talk to the doctor.
Right.
The beings that be said, no, sir. Not today. Oh, man.
Is it
I would-
maybe, Michael, is it an advanced, like an advanced lipid test? Is that what
Yeah.
it's giving particle
It's an
number?
advanced test, but there's a specific name for what it is, and I just haven't had the test done in a while. Where it gives you your oxidized score.
Is it clearly?
Yeah, no, it's not that one. And I remember when I first came across this, because doctors were telling their patients that they should take soybean oil because it lowers their LDL. But the reality is they may have lowered their LDL, but it increased their oxidized LDL level.
Okay, so my question to you is are all small dense LDLs oxidized?
No,
Guys,
not
correct me if
they're not all small dense LDL, I would say, is truly oxidized and where it can become problematic. But if you have a large quantity of small LDL and you do have damage in your endothelium, you're causing a much greater chance of things getting lodged in there, which in my opinion is kind of like where atherosclerosis really comes from. There's inflammation. LDL goes to the scene of the crime, like your first responders, basically. And when that happens and it gets lodged, your immune system realizes that there's a situation going on. So they'll send their macrophages over to try and help the situation. When they try to remove the LDL from a place it's not supposed to be, obviously the foam cell or the macrophage is having an issue being able to do that. It stresses the cell out, it swells up, becomes a foam cell. That then releases cytokines, which will now cause even more macrophages to come and kind of help out. And over time, those foam cells is what turns into calcified plaque. Is my understanding? Am I look at this pretty there, or?
Pretty there.
My
I would
understanding,
suggest to you that any small dense LDL has the potential to become an oxidized small dense LDL. And when that occurs, yes, the macrophages eat them up. And yes, that forms a foam cell. And yes, I believe, as you do as well, that the LDL was not, or the small dense LDL is not the nidus for causing a plaque or a Band-Aid, okay? I think as well as you do that an injury occurred, whether it be from sugar or insulin or smoking, alcohol, nanoplastics, microplastics, anything that can injure that glycocalyx, penetrate the endothelial lining. Now we cause a situation where a Band-Aid forms, and the Band-Aid can include cholesterol and LDL and macrophages and platelets and fibrin and all of these things to form a clot. That clot can calcify. Okay, that clot can also, I'll be right there. I got one talking to me. That injury and that clot can calcify over time. If the continuous injury, what happens is more and more of that debris builds up, and that gets narrower and narrower and takes years. The most common cause of a heart attack is not that buildup, because most blockages don't even occur until about 80% blockage, narrowing. And so what you're looking at is actually clotting. That core of that plaque can break off and go downstream, go to our heart, go to our brain, a brain attack, all of those things. Okay. So my thought is we don't want small dense LDLs.
We want the large puppy LDLs.
Right. But there's a caveat to this is, and what Selena and I talked about, and I'm seeing this a little bit more than I have ever in my past, is you see low insulin, a normal insulin, 3 to 5. You see low trigs, high HDL, and us as coaches think that person's in the sweet spot. But then that person gets a lipid panel like that advanced lipid test, right? And they got a bunch of small dense LDLs, and now they're freaked out. And you say, how could they're not eating carbs. How are they getting that oxidation going on? They're not eating carbs. I believe them. They're carnivore. They're eating moderate protein and they're eating high fat, and they're not eating carbs. And they got all these small dense LDLs. The problem arises is that person is not able to use all of the saturated fat they're taking in. And they're getting those LDLs are staying in the system longer, dumping off. They become a small dense LDL. That small dense LDLs gets oxidized because there is glucose in your system, and it's going to get oxidized by that glucose. Even though you're not eating it, our body still makes it. So now you got all these small dense LDLs because they're in the liver isn't recycling them. The liver can't, it's choked up. The liver is smothered. It can't accept you. When you eat all of that saturated fat, LDLs have to be made to carry all of the fat, right?
Yeah.
But it's supposed to recycle back into the liver, but the liver is full. This is the particular person that can't eat that much saturated fat. You have to lower their saturated fat, increase maybe a little bit of monounsaturated fat, increase their protein, because their protein is thermogenic and thermogenic. I mean, it's more highly thermal. It's going to burn more calories, which is another word that we shouldn't be using, but you get the gist of it, is that person has a risk of having a heart attack. Okay. They're at risk of having a heart attack, and you called them in their sweet spot, low trigs, high HDL, low insulin. Metabolically, they look like $1 million to the general eye until we got the advanced lipid test, which you went and paid for. And this lady, another lady might have gone and paid for, but in the general population who's going to carnivore coaches, they're just looking at the panel and saying, oh my gosh, this is the layman way to look at it. You look awesome. And then this person has a heart attack, and you go, how can that be? How can that be?
So with them having the small dense LDL reaction to consuming too many saturated fats, would that client also see other symptoms in other ways? Like they would have more diarrhea or dysentery because
they'll be fatigued. They're going to be having trouble losing weight. They'll start getting fat accumulating around their abdomen. Remember the abdominal fat, visceral fat?
Yeah.
The liver can't, they're trying to pump out all of these fatty acids and there's nowhere to go. So the liver is just choked up. It's like a stockpile.
Okay. So have you come across someone that is in this circumstance that doesn't have low energy and doesn't have a lot of adipose tissue sticking to, you know, their midsection?
Not enough that I could tell you I'm seeing correlation. I can't. I'm sorry.
So
I don't even want to go there, but I would encourage.
So if you're somebody that's fit, thin, you have pretty regular energy, those would then be signs that you would not be somebody that would potentially be in this category. Not saying that you aren't, but you have a smaller chance of being in that category.
Exactly. In fact, this population that I'm referring to, just so we're aware, is because most coaches will say, I think you need to increase your fat content. Or, as Selena and I talked about early on, they'll say, I think you need to add back some carbohydrates. That's where we're getting into this thing where influencers are saying, if you just eat a little more carbohydrates, but this could be the exact person I'm talking about that we don't want them to add carbohydrates because now they got small, dense LDLs and we feed this person with carbohydrates. We just oxidized all those LDLs. We caused a whole bunch of problems and increased that person's risk. When all we needed to do, they just can't tolerate all the saturated fat. Their body, for some reason, can't handle it. And yes, for the most part, and I'm talking generalization, Michael, if you catch that person and they're like you and they're lean and they got a six pack and their energy's great and they're sleeping great, and that's probably not the person. Okay. That you're going to have to be worried about. But still, should we just tell the person to get a $25 test and look just to be cautious? I think yes. Get a CAC score. Even if it's 0, it's a baseline. And 2 years later, check it again on your diet for this person, right? Mm-hmm. And if it goes up, if it compounds, you know that this person is not doing well with saturated fat.
Absolutely. So I need to hop in here. There is a question that has been waiting for most of the live. So Brian has asked, he said, I have a question. A good friend has trouble getting rid of gout. He is at least 12 months carnivore and recently lion. The problem, I think, the fact that he only has one kidney. Are there any thoughts?
So they're carnivore lion diet. And what are the, and one more time, what are they experiencing?
Elevated uric acid, right?
I believe so, yes. A good friend has trouble getting rid of gout. He is at least 12 months carnivore and recently has become lion diet. I assume that's what that's stating.
Oh, I think
the problem, I think, is the fact he only has one kidney. What are your thoughts?
I mean, the one kidney should usually compensate and take over the whole body system. But when we have elevated uric acid, you got to look at fructose. So somewhere in the line, I would make sure that this person is not eating any fructose. It could be a spoonful of honey that they're putting in their coffee that they didn't tell you about, but yet they're a lion diet. It just, you always got to ask all these questions. But usually they're either producing too much uric acid, consuming too much uric acid, or they're not excreting enough uric acid. Those are the three main scenarios. And so you have to go down each scenario and make sure, from my perspective, you need to make sure what is the reason for causing the uric acid. Now, uric acid is not always bad. Is the person having symptoms? If the person is not having gouty symptoms, maybe that uric acid is not a problem. Just my thoughts on it. But if the person is having some symptoms of gout, and they're noted to have high uric acid, I would start going down rabbit holes and finding out, is this person having a problem excreting it? I would check kidney function. You have to get a cystatin C, get a urine microalbumin. There's a lot of things that need to be looked into. Is their body making too much uric acid, or are they consuming it?
A question is I was kind of speaking with somebody that, I don't know if this is the same person, but it could be a little bit similar. And after reaching out to other people, because I really didn't know the answer, one of the things that I was able to get is that they were saying that, you know, it could be associated to oxalate dumping. Is that something that you're familiar with?
That long though, being on a carnivore diet for a year.
And that's the interesting thing, because I think I was talking
Although,
I
oh
was
my
talking
gosh,
with carnivore
Michael,
eaters. Yeah.
you brought up a good point. A person who has had a lot of oxalates in their system could take 2 years, 3 years to dump out. I'm just now, thank you. So you're onto something. It's possible.
Because that was the only thing that I was able to come to, because I mean, when you looked at everything else, and you've seen that in this client's case, or actually he's not a paying client, I could say we're more friendly. He's seen that those attacks have gone down. Like, instead of it being like once a week, it could be like once every 3 weeks or whatever it may be, to where he's still having gout issues, but the consistency of it, or how often, is slowly going down. So that was so after everything that I've gone through, the only thing that I could come to was it had to be oxalate dumping, and just be patient and kind of like keep going the course. Because if it is getting less and less, that shows that you're on the right path. It's just,
and initially when people start a ketogenic diet, especially a carnivore diet, the kidneys are actually going to dump a lot. So you're going to see it could take weeks to months for that transition, for the kidneys to not dump that uric acid or not have that problem, because they're dumping out sodium, they're dumping out pathologic water. And yeah, I get, uric acid can be elevated, I don't know for how long. I've never really seen it. I haven't seen elevations of uric acid for a year. I've not seen that, but I guess it's possible. I'm not sure.
and of course, in our community, we always come to those extremes, because that's why we're all here to begin with, because we needed to find another answer.
Yeah.
So a lot of times we always get very interesting situations.
Can you guys
Very
hear me?
true.
I can hear you.
I can hear you, Stephen.
Doc
Nope.
is still not hearing me. All right, so that's got it. All right, so at least it's, I
If
know it's
I
not
go
me.
out, I bet I can hear him. If he stays in and I go out and come back in, then I will hear him. So if you guys are going to be on for a while, I can slip out and slip back in.
Oh, okay, hold on. I want to find.
I'm not
That's-
going anywhere.
That's
it's
up to you.
guys.
I'll go ahead and do that.
I was going to say, I
probably
think
have
I know
about-
who. Go ahead.
About 15 to 20 more minutes on my end, and then
Okay.
I will have to hop
Perfect.
So as long as Steven doesn't jump out, I can.
off. Okay. Don't go anywhere,
I was
Stephen.
gonna say- I'm not. I was going to say, I think I know who Brian is asking about, because I've talked to him in the village. He's missing the kidney, and I believe he said he's having weekly gout flare-ups. And we did mention the oxalate dumping to him. And then also, like Doc had mentioned, a lot of people will say that they are lying, and then they'll go and put honey in their coffee or something. I've seen it so many times. Like, there's like, like I had a cup of coffee this morning and I'm lying. I'm like, like, I don't want to take away their lion diet card, like, and be like cultish or anything, but lion diet is ruminant meat, salt, and water only.
Right.
So a lot of people, like they like to lie to themselves, and I'm not making any accusations against this guy or anything. I'm just talking about people in general, where they run into problems because the ability for self-deception in the healing journey is absolutely incredible. And I say this knowing that I've been there myself, where, like you're like, I'm doing everything I'm supposed to be doing. I'm like, no. And I look back, no, I really wasn't. So that is that's something only the individual can answer for themselves. But yeah, the honey is basically high fructose bee vomit. And we, most of us understand that gout is highly, that fructose is highly associated with gout, high fructose.
Yeah, it's a 1-to-1 ratio of fructose to uric acid. So
How you
we
hear
need
me
to
now?
be. Yeah, I can hear you.
Awesome. I feel like
What I would suggest to you with your client, Stephen, when that comes up, when the answer that's not really lying, and they're telling you, and they you don't want to deflate them. So what you could possibly do is actually let it go. We as professionals get wrapped up into these definitions of keto, ketovore, carnivore, lion, and we got the definitions, right? To them, they're just thinking about their successes. But if it happens and you go, gosh, my uric acid level is high, and then you'll say, well, are you doing any fruit? Are you doing any fruit? No, I don't do any fruit. That's not on my diet. But every morning I put some, and then you could just say, but every morning I put some honey in my coffee. Instead of going off and saying, you know what, you're not lying. That's not lying.
No,
Instead of
obviously.
saying, oh gosh, I'm glad you brought that up. That's probably why. I bet it's that honey. Do you mean just that tablespoon? Well, it's possible. How about you stop the honey? You don't even went into the definition of lying. Just say, hey, I got a suggestion. I'm so glad you brought that up. Why don't we try off the honey for a month and see where you go? You almost got to, you gotta butter them up. You gotta tell them that they're doing a great job. And maybe we as professionals need to let loose of the definitions as much as we need to teach them more about fructose.
Yeah, absolutely. I agree with that. I only mentioned you're not lying because someone like him who has, he would probably need to be that restrictive to, with one kidney to get rid of the, and it might not even be anything he can do. He might have a problem filtering out the uric acid as you mentioned. So it might be, something he has to get diagnosed. If he's telling you he's lying and he's still having gout flare-ups, and then you find out, he's adding honey to his coffee or whatever, then, you don't have to castigate him for not being lying, but you can say that's definitely something that you might want to eliminate to get to the root cause of why you're having gout flare-ups still. Yeah, definitely.
Agree.
Hey, I wanted to ask you about, we were back on the LDL and heart disease topic. It's my understanding that the different lipid proteins are basically all the same structure. Like an HDL is basically the same thing as an LDL, whereas HDL just has more cargo, essentially. It's carrying more cholesterol, more triglycerides, and then as it delivers its cargo throughout its journey, it becomes lower density because it's offloaded its cargo, essentially. Is that correct?
It has unloaded its cargo. Yeah. You're correct. So everything starts out as a VLDL or even a chylomicron.
Yes.
Okay. And as it gets circulating into the system, then over time that VLDL to LDL to intermediate density lipoprotein to a smaller, it's dumping off its cargo, and we get the resultant HDL. Everything's pretty much empty. That HDL recycles back to the liver, picks up its stuff, and recycles. The fact that having HDL being protective, I'm not sure where that ever came from, because if you were to look at the chemical formula of cholesterol or chemical formula of a lipoprotein, you're likely going to be looking at a mirror image. It's the exact same chemical formula. If somebody says, I have good cholesterol, I got bad cholesterol, and I say, well, give me the chemical formula of your good cholesterol, and then give me the chemical formula of your bad cholesterol, and it ends up being the exact same thing. Right. Now, that's because we're thinking logically, and they're not, because they're in the time warp of good cholesterol, bad cholesterol, when cholesterol has the exact same chemical formula, okay? Mm-hmm. But yes, that HDL is carrying a lot of, remnants, so to speak, back to the liver where everything can be recycled. And so it's cleanup. I think of an HDL as a cleanup crew.
I think of them as like the policemen. Basically, your LDL is like your mass population going around doing business within the economy. And, and then as time goes on, some people don't have the best business sense, and they start doing things that aren't really exactly right to be able to get their money. And that's when the cops need to come in and say, what you're doing isn't right. We need to bring you back to the liver and rehab you so you could come back and be a functioning member of society again. So I've always looked at HDL as like the policemen. Everybody else is like, the LDL is kind of like your population. And then, you know, you kind of get your criminals that are doing their bad stuff. And that's where the policemen kind of come in. And then people will ask me to go a step further, is they'll say, well, you know, then why is LDL such a problem? And I said, well, if you're not consuming saturated fat and most of your lipids are coming from omega-6s that are already oxidized, your LDL's starting off oxidized. So it gets to the point where you look at these riots and there's so many people and there's how many police, and it doesn't matter how many police, there's just too many people for the police to be able to manage. So it gets to a point where it can't recycle it the way that it would like to, because all their cuffs are already in use. They don't have any other tools to be able to bring in more people or more lipids that need to be rehabbed to function correctly. And so that's kind of like the way I've always looked at it.
So that's interesting about the oxidation of the LDL, because I was always under the impression that under normal circumstances, you know, if your lipoproteins circulate through the blood and don't get stuck in the endothelium of the inflamed arteries, eventually they'll return to the kidneys and get recycled before they can be damaged. It was my understanding that the oxidation typically occurs when the LDL enters the permeability in the endothelium that's caused by the inflammation. It gets stuck in there and then becomes oxidized and glycated and then deranged. And of course, the immune system no longer recognizes it as you, and then attacks it with the macrophages and causes that inflammatory cascade. That's what I always thought was the problem with the oxidized LDL. That's interesting. With the basically the seed oils.
Sometimes I think, you know, and I could be wrong, but I think it happens long before. I think the small dense LDLs are oxidized long before they're going to the artery wall and doing any disservice to the artery. And I do think that there's a problem with the injury. The LDL, or the small dense LDL, it didn't cause the problem. It had to, the glycocalyx had to have been gone first. There's, the glycocalyx, I believe, now don't quote me, in a normal healthy glycocalyx, it's 8 millimeters. Okay. But by the time we damage that glycocalyx, that protective inner lining of the arterial lining, now those sticky LDLs, the oxidized ones, can get incorporated into the bandage. Okay. That's a good book that, if you haven't already read it, it's called The Clot Thickens by Malcolm Kendrick. It's an amazing read. And I think you're not going to get, you're educated enough that you're going to be able to get it. And I think reading that, you might grab, The Clot Thickens, just Malcolm Kendrick. I think you would benefit from reading it.
Very good. There's an excellent video on YouTube that I recently watched called, I think it's by Gary Fedke, if I'm not mistaken. It's called Carbohydrate, the Dose is the Poison. And he talks about, he's the first person I've ever actually heard mention the glycocalyx. It's basically these microscopic filaments, hair-like filaments that lines all of your cells and everything, but he calls it the largest organ in the body, actually. And it lines the endothelium of your arteries and veins. And according to him, one high carbohydrate meal can kind of erode your glycocalyx for 8 to 12 hours.
Agreed.
So that's
smoking a cigarette.
Yeah. Especially you consider most people eat at least 3, 4, 5 high carbohydrate meals a day. That's absolutely incredible and frightening, really, considering, its function, which is to moderate the, what gets to the endothelium and what doesn't. That's very frightening and very interesting. It's a very good video. I recommend everybody look that
I
up.
think I've watched it. I like Fetke. He's an intelligent man.
Mm-hmm. I geek out on this stuff. I got a whole playlist.
Nice.
Yeah. So sorry, I didn't mean to reverse course on the whole talk there. I got bumped out in the when I was like really excited to ask those questions, because it's very interesting to me. So good stuff. Good stuff.
Oh, don't be sorry. All of it's good stuff.
Yeah. I was hoping we weren't like just repeating things that you already talked about. That's the only thing I was worried about.
It's okay if you repeat things we already talked about. It just reinforces.
Reinforces. I agree.
Um,
Exactly.
so,
Exactly.
so now if you're somebody that has oxidized LDL in your bloodstream, or let's say you have small dense LDL that isn't oxidized yet, we know there's glucose in your bloodstream, right?
Mhm.
Will that glucose being in the bloodstream by itself cause that LDL to become oxidized, or is it the pressure of the heart? And when that pressure comes through, that's actually what forces that oxidation to kind of come further into play. Because when you look around the body, you don't see, the same calcification. You don't see the same issues in your wrist, in the veins in your wrist, in the veins in your leg, but you'll see it where your artery is, where there's a lot of pressure. So,
I
yeah.
would agree that the turbulence in areas where there's high turbulence is the reason why we have plaquing in those areas. There's not much
Absolutely.
turbulence in your vein, and that's why you can use a vein as a graft for a cabbage, a coronary artery bypass graft. But once we make the vein into an artery, now that vein graft can become plugged up. And in fact, it gets more plugged because it doesn't have the mechanism of being an artery. It's acting like an artery, but it's not. So yes, I think turbulence is a huge thing. Pressure, wherever there's a turbulent area. That's why there's skip lesions.
Mhm.
If it was all just one thing, then you would have the whole lining, but we have them, 1 centimeter long an area, or not even, I don't know how many millimeters of a plaque inside an artery, but that's why we have areas, in our neck. And I've seen a carotid endarterectomy. I've been live where the doctor will just pull out the whole lining of the carotid artery and it all plaque. But if you look on an area of your heart, there'll be just like lesions all over. Now, when I think about pressure, I think about blood pressure, right? That's turbulent. Why do we have blood pressure? The most common cause of high blood pressure is high insulin causing pathologic water retention. And so when we start whittling down and working backwards, we go, oh, root cause here, right? Is it all just sugar? No, it's smoking and drinking and nanoplastics and all that. I mean, diesel fumes is a cause of glycocalyx injury. There's so many things. And so I hate for all of us to be reductionists and say, if everybody just followed a carnivore diet, no one would have heart attacks. But they're following carnivore diet and they're working, painting in a detail shop, and they're working on diesel engines. They get a heart attack following a carnivore diet. CAC score was 0. Then it's 0 now, still have a heart attack. Something injured the glycocalyx.
You know what's something that I find very interesting, and this isn't exactly diesel related, but it's kind of fumes from like smoke, is they say like when you're consuming smoke, it causes issues within your lungs. There's all these different side effects that could come along with it. And I'm sure they'll also say it'll damage your glycophilics as well, I would assume. But there was this person who, and I can't remember the podcast that I was listening to, but what he was saying is when he was looking into an indigenous tribe that basically is living in a hut that's filled with smoke like year round, like they don't have lung cancer, they don't have lung diseases, they don't have any of these issues. And what I found really funny is then they started going really interesting is then they started looking into the actual linoleic component of what these people were consuming based off of their ancestral diet, which all of them is less than 2%. And in most cases, it's like 1.5% linoleic acid. So when I start looking at all these different things, and I know we've also learned that if you don't do anything, it takes 2 years for your body to be able to recycle all your fat cells, which is also where this linoleic acid can be stored because our body doesn't know what to do with it. So if our bodies are balanced correctly, would those diesel fumes actually have that same reaction? If our body's protected the way it's supposed to? Because what I find, and this is something that blew my mind and made me started looking at linoleic acid from a whole different perspective, was when they want to study something and see if something can cause cancer, the first thing they have to do to that lab rat is they change its diet to where now their linoleic acid consumption is above 3%. So they know that if it's not at a certain level, they're not going to be able to have a study because it just, everything won't match up. So when you now take that, you need to be above 3%. And then you look at our entire population that's consuming like more than 50% of their diet from omega-6 linoleic acid because they're not consuming saturated fats. It's kind of like, is everything that we know and what causes it, is that really what's the true cause of the diseases? Or is it, again, based on that that single ingredient, which is having too much of an imbalance of omega-6s in our body that basically throws the epigenetics within us into a haywire? Like, things aren't turned off.
That's a great point. And, you know, if you were to think about, you mentioned an indigenous population where they're just eating animal products, right? In all animals, you're going to have omega-3 and you're going to have omega-6, but they're in a 1-to-1 ratio. And natural animals will have antioxidants like vitamin E. Okay. So you got natural antioxidants coming in, and you have a 1-to-1 ratio. Our typical American diet is actually not 1-to-1. It's 10-to-1, 20-to-1, 29-to-1, omega-6 to omega-3. All of those polyunsaturated fatty acids is getting oxidized because of all of their double bonds. So if you just ate naturally occurring animals, you're getting a 1-to-1 ratio and antioxidants. Okay. So I think I could put you, like you said, they could be in the hut with the smoke and the burning and yet not have this injury to the membrane. But again, you're putting all your chips into it's polyunsaturated fatty acids as the cause of heart disease. See what I'm saying? So
Yeah.
I think it's a combination. It could be the sugar, the insulin, the PUFAs, the plastics, the diesel fumes, the iron overload. We didn't even mention that. And we could do that another day, but all of the heavy metals that are in our body, all of these things that population that you're talking about they're not drinking out of plastic bottles, and they're not breathing glyphosate in the air. None of that is occurring. And so we're trying to take one study, and then they feed a rat full of fat, which rats don't eat that fat. They had to inject it, right? They had to inject it. They're not going to eat that stuff. And then you're going to do a study because they're just like us. No, they're kind of like us maybe, but it doesn't work that way. But I hear you're thinking logically, and I love that. We're talking, and nobody's right and wrong here. It's just like, let's think logically here.
Yeah, like, I look around, you go to nature, you don't see animals with disease. Then you change their diet and you put them in an unnatural situation, and they have all the same diseases that we have. And the only way that I could look at it is, at the end of the day, like, we're chemical beings. We are a living organism, and everything in our gut, our microflora, our gut microbiome, everything is chemical. So if you're at a point where now you are starting off the equation imbalanced, how are you supposed to be optimal? And it's like the smallest things. Like, I don't know if you heard about this doctor in Africa that literally claims that he's cured almost every disease his patients has had by telling them to take their shoes off and connect with the earth. From cancers, I mean, it just goes down the line, which, again, comes down to that electrical imbalance. When we ground, we become electrically neutral. The way that our body is supposed to function, our red blood cells separate, everything becomes better. So if we start putting things into those equations that aren't supposed to be there and throws everything off to begin with, like, yeah, we're supposed to be there. So for me, if I'm worried about cancer, I try to limit my omega-6s to where it's not imbalanced, because I feel like cancer derives directly towards that. The omega-6s is going to throw off all your hormones. It's going to throw off the way that it's going to affect the cannabinoids. It's going to the way your body stores fat, your hunger, all these different things. And I truly believe that cancer is a metabolic disease. And if you're somebody that is over consuming all these different aspects, and then you also have the imbalance of the omega-6s, it puts you as a prime candidate to say, hey, like, this is imminent, and it may not happen tomorrow, but you are now the perfect storm for when cancer would come to be. Like, for me, my biggest fear is, like, I have cancers that run in my family. So, like, and I just recently put 2 and 2 together, but I used to eat so many chicken eggs. And even when they say they're corn and soy free, they're feeding them so many peas and so many different vegetables, which chickens don't eat. And now when I eat an egg, and I don't know if it's because the omega-6 to omega-3 balance isn't what it's supposed to be, but I used to eat like 10, 12, 14 eggs, a day, 5 days a week. Now I'll eat an egg, and it's like, for some reason, it's like, I don't want to eat it. And I don't know if it's to a point where, like, your body gets so inclined to, like, what's coming in and understanding, like, this is what and now suddenly it's like, oh no, this isn't right. We're getting more of what we need to, like, we don't want this. And then, you start to have subtle changes. So I don't know. I mean, I don't know if you agree with my perspective on that, but I feel like if you're worried about cancer and health, at the end of the day, you make sure your ratio is correct. And if you're worried about heart disease, you limit any other things that could potentially cause inflammation. And that's like anything that's chronic. That's making sure that, like you said, you're not over consuming anything that has heavy metals, which unfortunately is in every single thing we consume. I mean, there's lead in your sweet potato, there's lead in your wine. I mean, it's everywhere. So we kind of get ourselves in a situation that if you start consuming things that we create for the end consumption that's not given to us by God, it seems like you're putting yourself in a situation for, becoming sick.
Yeah, I would agree with Dr. Malea that like carnivore should be kind of like one big aspect of an overall lifestyle of harm reduction. Like you want to clean your diet up, but you also want to get rid of the plastics in your kitchen, get rid of the Teflon in your cookware. I use bamboo cutting boards, glass storage, stainless steel utensils. I have a bamboo toothbrush. You're never going to. We live in a toxic saturated environment where you're never going to get rid of all of it. I mean, there's glyphosate in the rain, so there's really nothing you can't fully purify yourself, but do like everything you can to get all of it out of you and away from you, and then you'll have a good chance of letting your body take over and do the rest for you. But I do everything I can, to stay away from it as much as possible. And the grounding also is super, super important. Something I don't do enough of, but that's absolutely real.
Yeah. I think there was a study that was shown, like, when you fly to another country and you experience jet lag. So
Yeah.
from what I was listening, they were explaining that our bodies, for whatever reason, the sun isn't up, and at 4 a.m. our body starts to release cortisol to get you ready for the day. Well, if there's no sunlight, what's triggering it? And it all comes down to energies and frequencies, right? Because we're energetic beings. So what they were saying is one of the best things you could do when you travel is in another time zone is take your feet up, take your shoes off, and ground. And if you can, ground for as long as you can, because it actually allows your body to kind of like reacclimate to now what the new frequency is of the area that you're in. Which I found fascinating. I haven't had a chance to travel international to test that yet. I will say over the summer not over the summer, in September, I went to Europe and I was we started off in Croatia, and the first day I felt really off, and the second day we were swimming in the I think it's the Aegean Sea. And after I went in the sea, I mean, I felt incredible and I felt good and I felt balanced. And then later on, I could listen to this podcast and it brought me right back to it. And being in the ocean is one of the best grounding situations you could put yourself in. So now that I look at the two of those things together, I find that interesting. But then what it shows is that jet lag is not really a circadian, it's not a circadian rhythm thing. It's more, in a way it is, but it's more a cortisol thing. Mm-hmm. So if your cortisol is off by just an hour and it's not flooding your system at the right time, your body is going to be like is going to be in disarray for the day.
Right. Absolutely. Okay, so as beautiful as that topic is, and one of my favorites, I am going to have to shut us down. We have been on for almost 2 hours and 15 minutes, so we have reached, I think, a new record.
I saw that. That's awesome.
But this has been such a beautiful, informative, amazing conversation. And I do want to say, Dr. Jensen, your passion, your awareness, your willing to look at your human aspect as a doctor has moved me tremendously. And I am so grateful for people like you that choose to acknowledge what your responsibility is as a doctor. So thank you for that.
Yeah, I hear you.
Also,
and I want to thank you guys for having me as a guest. It's an honor. And you're right. I am passionate about this. I'm passionate about, even if I could just, like Steven said, if you can just, or Michael, help one person, you've changed their life. And
Absolutely.
Selena, just sharing your story with me is just, unbelievable. And Michael's got a story, and Steven's got a story, and I got a story. Okay.
Right?
So the more and more we share these things, the better. And it's just an honor. I just come from a little bit different perspective, and I can shed light on what it means to be coming from a situation where most people look at doctors in today's world as, just ignorant shitheads, to be honest. And not all of us are like that. But I might have been one. Okay. And I admit that.
I think we all are ignorant assholes at some point in time, or whatever label. We all are. I mean, there's still things for sure, without question, I'm ignorant on, and I don't have every answer and everything on. But acknowledging that we're willing to be open to that is such an amazing aspect as human beings, for us to be able to share that it's okay not to know everything, everybody. It's okay. Our egos can be left at the door.
It's okay to admit it.
Right? Okay, so on that note, guys, we are going to shut it down. So until next time.
Love you guys.
Thank you.
Good talking to you.